Top Med Talk.
Today's Top Med Talk is a two-part piece. This is part 2 and part 1 has already been released. Please check out the show notes for more details.
I'd like to move maybe on, if everyone's happy, to talk a little bit about Pacu Models. What's this Pacu Models of care? Who's got experience with Pacu? We're talking here about post-operative care, and Pacu probably means different things to different people. So maybe we'll start with a definition. If anybody wants to tell me what their experience of looking after patients post-operatively is and in what environment.
I can offer some insight from my background. So I did my advanced peri-op training in Cardiff in 2018, and Dr. Anton Simon, one of the intensive care consultants, very much took this under his belt in developing a PACU, so post-anaesthetic care unit, which was on the same level as intensive care, but on the other end of intensive care. So it was a standalone unit with its own nurses, which were ITU trained nurses, and it's ring-fenced 4 beds. Been fortunate to work in different PACUs, and I know there's different models, but this one works where the patient comes into hospital and is designated their own bed on a surgical ward. They physically go to theatre and then come back to PACU on their bed, which means that yes, their bed is empty on the ward, but what it does mean is when they're ready for discharge, they are out the next morning if and when they're ready. And this promotes and allows flow, and you don't get any delay in new admissions into bed blocking. So it was a successful model. And in that year alone, we got over 500 cases through that. Majority often are cancelled on the day when you're trying to negotiate with intensive care bed capacity. And those cases were including months where we did have to close due to winter pressures, where the nurses were pulled back to intensive care. And despite those weeks that were closed, we were able to get a lot of cases through that would have been cancelled. And based on the efficiency and the flow of the cases and patient satisfaction, what government helped to fund an extra 5 beds. So hopefully COVID has delayed things, but this year they're looking to expand their PACU capacity, including emergencies as well as elective cases through.
Is PACU different to intensive care?
Having seen, and so UCLH, for those that don't know, at the moment has a very much more integrated PACU. So their elective cases are mixed in with the intensive care patients. And I think seeing both PACUs and how they're run, it does lend itself to benefits for each of them. So particularly the one in Cardiff, when you've got an isolated PACU, you do see a different mantra because the nurses are trained, and it's very evident. They're looking at the allergies, they're getting them out of the bed the next day, they're getting them fed. You just notice a whole MDT approach. The nurses, the physios is more about rehab, and just the whole mentality is very different. Not to say it doesn't happen. I think it's more challenging in integrated intensive care PACU setting when you do have a multi-organ failure patient that is really sick or NORAD and they can't have that. And you've got your elective patient who's just sitting there quietly. I don't know, sometimes it can be lost, that peri-op pathway, particularly in those settings.
So, in summary, you're suggesting it's separated from acute care. It's elective, it's sort of ring-fenced, and it's looked after by people who have intensive care skills for sure, but actually are thinking a bit more widely, if that's not a criticism. It's not meant to be a criticism, but just thinking slightly differently about the journey for the patient and that period of time that they're sitting on something that looks like an intensive care.
Yeah, absolutely. And I think it's integral, as you mentioned. It's a multidisciplinary. You've got the surgeons, you've got the intensivists, the anaesthetists, the pain nurses, the physios. It's very much a multidisciplinary, but you're on the same page in the peri-op pathway of the patient.
Yeah, I understand. Anybody got any comments about that? I saw a lot of head nodding as if people have bought into this culture.
Well, I just think it's different to as Isra was saying, the kind of drive to mobilise and to think a bit more about, because it's post-anaesthetic, it's not, you're just trying to get that person over there, over the initial the surgery and trying to get them back into their recovery phase, rather than maybe in the intensive care unit where you've got someone who's maybe more multi-organ and, multi-organ failure are going to take a little bit of time. I think Pacu focuses a little bit more on trying to rehabilitate, get people moving quickly. And that was what I saw in UCLH, and I think was really inspiring to see people the night of like a major surgery. It's just a culture of trying to get them sitting out straight away and mobilizing as soon as they can, and rather than waiting to the next morning for people to come around and say, I just think it was a different priorities, and it's maybe a bit lost in a mixed unit where a person who's come in, with sepsis and is on multi-organ support there's a different trajectory for that person from the person who's come post their anaesthetic and just needs to be monitored overnight or for however long, but has an opportunity to still make progress within that trajectory.
Being devil's advocate, anywhere in the hospital can be Pacu, put a label on the front door, call it post-anaesthesia care unit, leave the arterial line in so there's a few extra squiggly lines on the monitor, but ultimately it does come down to that proactive monitoring and observation. And that culture change of, is the patient okay? Can they hear me? Can they see me? Have they got their glasses? Have they had something to eat? Are they thirsty? Are they allowed to eat? Getting them sat out, and then noticing those bits that, oh gosh, that doesn't seem quite right. Not to say that we don't do that at ward level, but this sort of idea of an enhanced care, this sort of level 1.5 sort of patient, and that's exactly the candidate you want in that proactive in that ward. Very easy to call it a Pacu, but actually get down to the nitty gritty of it, and then it's really the education and the staff and the collaboration. I think.
Yeah, it really depends on that patient. Like the patient could be anywhere in the hospital in a ward bed, which is who's looking after the patient that makes the difference. Maybe going back to what an older model was maybe 10, 15 years ago, where as anaesthetists probably would have gone to see their post-ops the next day and followed up on them, make sure everything was okay. It's kind of rejigging that model in a way that's a bit more organised.
I was just going to extend on from that idea that, these patients can be on the ward, and that with the advancement of technology, and virtual telemedicine, you can have these observations being done in a remote ward and having somebody central observing them. Now, there's questions around the ownership of that data, but at least the patient is monitored. There's somebody sensible looking at those observations, as well as the ward care staff. So virtuality and wearable technology certainly is where we're going to go, I'd say, very, very soon.
Mm-hmm. Are you making a case for culture and leadership being the leading principles on this service? Presumably, yes.
I guess the anaesthetist is the orchestrator. They have a good concept in terms of the whole model of care supported by all the other disciplines. But yes, I would be advocating that's naturally happening. It's been happening for many years, and it's just coming to the fore now, really, where that culture change is coming into practice on the front line, which is great to see.
Good. And I presume anaesthesia, you would say, Guy, has a role in this concept of failure to rescue. People saying patient was fine when they left recovery. Is that longer tenable? Do we have a bigger role here?
Absolutely. I suppose it's one of the key performance indicators, really, and that's what we should be evaluating our service against. And the rate in third level, even not even third world countries, even everywhere across the world, the failure to rescue, it's still there. Those complications that we could have prevented by that proactive cultural change, and so that failure to rescue, it shouldn't happen. It's completely preventable.
I suppose that's where we think about integrated care, collaborative pathways, because I think the anaesthetist may play a role in may play the primary role in some places, and maybe in other places it'll be a different team member, but just trying to share expertise for whoever and cross skill and try and get, a collaborative approach doesn't really, I'm not clear in my mind if it has to be an anaesthetist or if it has to be, for example, a geriatrician or a surgeon, but just that we are articulating or we're advocating for the patient, and whoever does whoever effects it, it may be different in different hospitals depending on staffing or interest or, but,
Mike,
it's not just
you're gonna
the domain of one person.
There's a delightful question that will probably throw a pebble into the pond, but plays very much into that discussion, which is if somebody wants to be a perioperative physician, then what specialty should they train in?
Let's go to Roisin and ask her directly.
So it actually, perioperative medicine, I suppose, like I would call myself a perioperative, a geriatrician with an interest in perioperative medicine. It actually is part of the geriatrics curriculum in the United Kingdom. So perioperative medicine has made it onto the curriculum in the UK, and it does form part of the Irish curriculum under orthogeriatrics. I think it is going to be multi-professional. Like I think the vast majority of medicine is moving that way anyway. It's not just within perioperative medicine, you know, and I think it is going to involve not just, you know, physicians, anaesthetist, surgeons, doctors, but, you know, nurses, everyone. But I think probably anaesthesia is the base specialty, but definitely I think if you have people who are enthusiastic and want to be involved, that's going to be the main driver of it, regardless of speciality. It's just people wanting to do the best for the patient.
How do we train? How do we move from where we are today to where we want to be? I've heard it said that perioperative medicine is for anyone who's trained. So what are we doing about training? Anybody any experience with training people, teaching? What's the curriculum look like? Who are we getting out there and preaching to? Anybody?
So I've got particular interest in foundation teaching. So that's UK System Foundation Programme doctors. And when I was teaching them, I think we started 2018, the teaching for them. It's not actually in their curriculum, and the revised curriculum that's come out, and it's still not a standalone module, but there's elements that are very much peri-op, that are called peri-op, but it's not a standalone specialty at the moment. But I think there's merit, definitely undergrad and in the foundation doctors of educating them peri-op, because they are our future cardiologists, anaesthetists, surgeons. And for that reason, it's important. But also, it was a great tool for them to go back to their team to talk about how to risk stratify patients, how to optimize them. And we had such great feedback from the sessions that we have pitched it to the national foundation program to try to get it in the curriculum. So it's definitely should be, I think, started to be incorporated in the undergrad and foundation program, as well as across surgical specialties. Anaesthesia is very much implemented, and in our new curriculum, it's highlighted. I think most specialties are now looking at it and think that to be involved with.
In the UK, I guess the Centre for Perioperative Care, CPOC, that idea that the colleges of surgery, anaesthesia, nursing, general practitioners, geriatricians have collaborated. They formed last year, and they have a pretty good vision and a plan, and have a framework in terms of QI, research audit, but also have curriculum standard settings, so that those colleges, as Roisin mentions, geriatricians have it as their core component for their training. The College of Anesthesiologists, as it's now called in Ireland, this week are going to announce their curriculum, and central to that, a core competency is perioperative care. And so I think exactly what Isra says, this is going to develop, and in Ireland certainly, and even in Wales and across the world, it would be great to see that sort of collaboration, like in the United Kingdom, where they have the CPOC, that Centre for Perioperative Care, with that kind of cross-specialty collaboration, I guess.
Yeah, I've often wondered if it's time to lose questions on the Wheatstone Bridge and stick in something on frailty. It might be better, do you think? Gone the hair hygrometer.
Absolutely.
Yeah, I'd back that one.
And that's grassroots. That's what the fellows can do. That's what the trainees can do. They can say, could we have a curriculum which is living and breathing and reflects the job we are inspiring to do? You should feel free at any time to feed that back to people. And I think colleges, in my experience, are very much moving towards curricula which much more reflect our patient population. So I think together it will be fine. Anybody got any experience in training? Australia? What does training look like in Australia?
The current role that I'm in is quite a niche role. There are perioperative medicine ships elsewhere. The one in Peter Mac that I'm doing is quite a blended mix of clinical management of the patient from the preoperative side through anaesthesia and then into the enhanced recovery as well. So it's, I think being in a cancer centre is very different to the experience that maybe a perioperative fellow would have somewhere large like, I suppose, any major tertiary referral hospitals. You see different patients and you kind of, I suppose the emergency surgeries are not common and are well flagged usually before we would have to undertake those. So it's a very different fellowship, I suppose, to being a tertiary referral centre where you've got other major cases such as AAAs and other vascular cases and neurology and things like that would maybe enhance things a little bit more in terms of management of that patient on the perioperative way.
Kim and Isra, you are leading a piece of work, and I asked the group whether we think it's important that Team Anaesthesia gets out there and trains other people or helps skill up other people, and what we see our role in as leaders and supporters and trainers of people who aren't traditionally in that role. I'm thinking particularly about nurses who probably have a more influential role in the recovery of our patients than doctors. You've been doing a lot of work on that. Any thoughts on how it's going and your feelings about training other groups?
Yeah, so just a bit of a background. I've been involved the last year now in a online program, but it's reinforced with face-to-face with the recovery nurses, doing an 8 online module looking at airway, breathing, emergencies and covering pain. Just in view of more and more patients coming through to recovery that are high risk and requiring more monitoring and going to Pacu, we thought that this is actually a great opportunity to educate and involve the recovery nurses. And a lot of, when you look at the nurses' surveys, a lot of them are not happy of the amount of teaching they have and they don't feel valued. And this was started off a very informal teaching, but based on the feedback became something a bit more formalised, and we're looking to get accreditation by the Royal College of Nursing. So it's an online module that nurses do, and then 45 minutes every week where they see a pulmonary doctor. And we've had great feedback, especially, unfortunately, COVID happened, but actually the skills they have started most of the modules before COVID, and a lot of the Pacu nurses then, they went from recovery to helping with the Pacu nurses and got more comfortable looking at CO2, looking at the arterial waveform and knowing a bit about it and how to manage patients. So based on that feedback, actually, it lends itself for work training up the Pacu nurses. So I think it's been great to get involved, and it's been very nice for team building as well. I think that's what one of the feedbacks is, that they know who we are, they know what we want, and they feel part of the team. So far, so good.
Yeah, I think it definitely lends us then into being able to expand the service. So the upskilling of these nurses is essential in the next couple of months and weeks even, because we're expanding a Pacu in UCLH to overcome the blue versus green pathway for COVID patients. So we're trying to keep elective surgery running, but we're trying to open Pacu in the Pacu that was in the main ICU on a separate ward, so that we can facilitate elective surgery throughout the winter period. So we're not only involved in nursing education, I'm starting to do a project on upskilling the junior doctors, so not just the F1s, F2s, or the interns. So there's going to be surgical SHOs rotating through the Pacu as well, and they're going to need to be upskilled. So the same kind of teaching will be needed for those specialties as well. And then that will hopefully be linked back long-term into their college. So the Royal College of Surgeons, the Royal RCPI, or the Royal College of Physicians could maybe take on modular programs as well for their trainees, that perioperative medicine can start to be integrated, not just in anaesthesia, but also.
I think elderly care similarly are pushing on with teaching and training. I mean, here in the UK, the British Geriatric Society, very active and proactive in looking after the surgical patients and training the new cohort of doctors coming through. Any experiences with conferencing elderly care conferencing, and Roisin, in your own experience of training up through the British Geriatric Society, well supported?
Yeah, definitely. And I think it probably started in the UK, and it's expanding to Ireland as well. But definitely, I know the team in Guy's and Thomas's, and there are other centres. I was in Southmead in Bristol, and people sort of share that experience. I know there are a number of people in Ireland as well who have maybe trained in the UK and have taken some of that experience back. But again, I think it's just about being proactive and enthusiastic about it. And just, I think anaesthetists have always been very welcoming to me, but just that shared learning. And I think there is a lot of that, you know, like, for example, like I'm at your conference now, or, you know, people going crossing the disciplines and sharing that knowledge. And I think people are welcoming that, and, you know, that's the way things are. And I think it has to be welcomed, yeah.
Super, that's great. I am seeing lots of teaching and training programs springing up everywhere. I think it's great. Mike, somebody out there in the audience want to ask a question?
So we've got a question which I guess bears more on the leadership agenda from an anonymous questioner who says, there's no peri-op medicine service in my brackets Irish hospital. There's also no interest or engagement at a surgical or management level. How do I change this?
That's great, because I'm looking at my little list of things I've yet to cover, and I don't want to preempt what people say next, but I've got here national databases, data, and whether that may lead into the answer. Anybody got any experience of what to do, how to change hearts and minds? Because it is really all about the pounds, isn't it? It's about pounds, shillings and pence, and it's hard.
So in Ireland, there's no national database that we can really refer to. There might be a national hip fracture audit, maybe a trauma database, but nothing available to the user on the front line to say, gosh, how well are we doing for insert your specialty in surgery here? And so having worked in the UK, where there's a well-established emergency laparotomy audit, each individual hospital can access their data, can look at how well their surgeons are doing, how well the patients are doing, length of stay, and bringing that to management to say, look, gosh, when we started doing these sensible things, we reduced our length of stay and we were able to save £2,500 per day or whatever it is. Management are pretty quick to listen there when you come over with your euros, your cents, your pound, your bitcoins, whatever. If they can save money, get more people through, then they're going to listen. In terms of colleagues, then engaging colleagues who say, look, perioperative medicine is a whole load of nothing. I can come to them with that data, collect that data, say that Mrs. X, had her surgery. She left hospital quicker than we thought. She got back to doing the golf that she wanted to do, because you remember that shared decision making we did? We followed that up. So rounding that conversation with them, and I just think it's with the clear communication with those teams. I think being persistent and having the data to hand would probably help in that particular situation.
We're trying to put ourselves forward for this as well. And just to piggyback on what Pádraig was saying, you have to show the value of it. And if it's the surgeons, you have to, what do they want to see? Is it that they want reduced bed days? Is it that they want reduced mortality? What do they want to see? And go to them with, your carrot on a stick. Like if I get involved in this, I can reduce your bed days by a certain extent, and you have, higher throughput, but it's just trying to find a way in with them, be enthusiastic, and but talk their language. If you're going to them, you have to make sure you know what they want. And again, it is all about improving kind of care for the patient, but what is their metric? What do they want to see at the end of the day as well? And that can be your in.
I can't remember the last time I met a surgeon who didn't want what we want, or a manager. In my experience, I've been very happy to sit in my silo and pretend I'm the only one who cares. I think it's about engagement, isn't it? About a shared purpose and all of those sorts of things. And it's difficult. Anybody got any experience of using real data, their own data, to affect change?
I suppose in UCLH, based on the NELA data, we were able to compare our hospital to other hospitals and other trusts and realise that comorbidity mortality was significantly higher to the norm or the average. But we've implemented a NELA outreach round now. So the POM fellows follow up and see all emergency laparotomy cases on the ward. And that has significantly improved and reduced the morbidity mortality of these patients. They're increased, they've reduced length of stay and reduced morbidity mortality, and overall improved the national average of our data. So that was something very simple that we identified because of this national database and implemented locally that made significant changes within the hospital system, but also improved care and outcome for our patients. And I know that's a service that was not only delivered in our hospital, but I know Roisin herself I know you've also delivered a similar service as a geriatrician, and has significantly proven benefit as well when you were in Bristol.
Similar.
It also lends itself to the idea of, I don't think outreach is like the right term for it, because when you refer to outreach, it's like ICU outreach. But I think we should have a POM follow-up for patients, maybe that might be the correct term. So any kind of majorly complex patients that you can identify in the post-op period, that they should be maybe followed up on the ward by a perioperative medicine doctor, be it a geriatrician, be it a physician, be it an anaesthetist, and they be followed up and monitored in the post-op period to avoid that failure to rescue, to avoid that readmission to ICU, and to improve the length of stay and outcomes after surgery. So I think there's scope for that as well within perioperative medicine. And it's something that can be very easily implemented in our end as well, I feel.
I was taken by that data that Monty and others have shown back 2008, the National Enhanced Recovery After Surgery program, and the impact on bed days was immense and a real stimulator to us back then to really do our best to drive the process, because there was something tangible we could see there in terms of benefit. Anybody got any experience with ERAS? ERAS is a term that has been bandied around a lot, really, and everybody says they're doing it and they're doing it well. Anybody got any experience of it, sort of people paying lip service to it, or are we now really doing it? Mike, there's somebody out there. Do they want to talk about ERAS or something else?
No. It was there's a couple of questions. One I can come back to, but one was really a comment on the discussion we've just had, which was reasonably forthright. You said, put the patient front and centre. The patients want this. The hospitals will have to comply.
I suppose we don't really, culturally here, we're not really looking at those measures as standards. So we're not really asking patients routinely about outcome. Preoperatively, maybe we need to expand that opportunity to talk about their preferences and about their goals preoperatively so that we understand what the targets are. That's the shared decision-making conversation by another name. And then I suppose, we need to describe and measure, which I'm not sure that we do routinely at the moment, but that's the information that we should be looking for, because everything else is, marginal gains really, but to put the patient front and center and try and improve the outcome for them, that's the mission for periop medicine.
Improve the patient-reported outcomes are improving and more positive with perioperative medicine. I think the financial benefit of it will follow later. So I think when you're trying to pitch the idea of perioperative medicine, you will get the financial gain. It's not in the short term, it's kind of more of a long term. So I think that always comes back in argument to a new service or implementing something new, that you need to kind of show the financial gain initially. But I think if we show more on the morality of we want to deliver the best care for our patients at the right time in the right place, and improve their overall experience, I think that should start to win out in terms of argument to implement change.
Okay, so as we begin to draw the session to conclusion, we've got 5 minutes or so to talk a little bit about what's the ask then. What's the plan?
I wanted today to take the opportunity to pitch the idea of IPOMS, or the Irish Perioperative Medicine Society. So I'm taking a leaf out of Isra's book and her WPOMS, and also the EBPOM and TRIPOM, and kind of bring this concept to Ireland. So a society, be it a group of interested physicians, geriatricians, surgeons, even physios, pharmacists, anyone who's interested in perioperative medicine that could join and be a supportive group and a listening ear, both from an educational point of view in terms of perioperative medicine, being a link to the colleges for education training purposes. And be kind of an educational support group for fellows, be it in Ireland and internationally. I wanted to pitch this idea to the discussion group here, but also to the wider community in Ireland in terms of, is this something that we want? Is it something that we want in developing the next, well, now or in the future, basically?
You made the UK sound really good. I heard 3 or 4 times there that it must be a really great place to practice medicine and perioperative medicine. I'll just fly the flag for it being very difficult still at home, and the problems that perhaps you've articulated in Ireland remain our problems also in the UK. We're on a bit of a journey too, and your problems are mirrored back home here. So I don't think we're that further on than you, in spite of the impression we all give you. I think there are some great people on the stage talking perioperative medicine and they are perhaps the future champions. But life is hard in the UK too, and I think we're trying to walk that walk. I think it's a fair comment. Guys?
Can I just say something? So I think with Ireland, similar opportunities exist with Wales. So Wales is very much a small country, but we've got over 7 health boards. And the reason why we set up WPROMs is because there's great work going, but it's often quite siloed. So you can go to another hospital, seen a recent guideline that just presented another hospital. So WPROMs aim for basically sharing ideas and networking amongst each other, to make sure we're not duplicating work and we are sharing great ideas. And I think that this would be a great opportunity for Ireland to also have that collaboration to show what's going on. I think it's just a great opportunity for the anaesthetists, for the surgeons, that everyone that's got interest in peri-op. And what was surprising, what I found, how many pre-assessment who had come, physios, dietitians, people that were keen. So we had over 110 delegates at our first conference, which I think for a small country is quite impressive. Yeah. There's a desire for that, and I think that Ireland has the same opportunity to take this forward.
Yeah, very well supported in Wales, and well done for you for getting that running, I guess.
So I've got a couple of comments and then that question that we've got outstanding. So first one on IPOM. A national society would support POM implementation and education in Ireland, clearly supportive from Niamh Hayes. An anonymous comment, which is great for EdPOM. Outstanding panel. The 5-to-1 girls to guys ratio. Future of EdPOM with a big smiley. And then a question from our old friend Michael Swart, so old friend of EdPOM and Dingle, and also obviously on college council and very much involved in CPOC. Have there any of the panel come across any tensions between different specialties who are involved in perioperative medicine? And if so, how do we manage this?
I think
we all like
it really comes back to the patient being the centre of attention in this whole discussion. That's the primary goal, to look after that individual from start to finish. The tensions that exist between people, I suppose, examining those and figuring out other people's drive for those tensions or causes behind them, presenting a more collaborative approach for that individual who's going through this journey is the most important thing.
I think maybe this is naive, but I think because it is quite a nascent sort of area of practice, the tensions aren't so well established. Like, I think this is all opportunity in my, like, say, for example, just my minimal experience of trying to do this in one institution in Dublin. Like, people are just really enthusiastic about the idea that there might be an opportunity to identify a higher risk cohort that then could have some proactive input perioperatively. Like, that's the proposition. Like, and so far we've been met with enthusiasm from particularly our surgical colleagues who are, they're the ones, I suppose we have to, that's how we'll get our referrals really. Like, so the patient is at the center, but we have to work out who are the people that are going to filter the patient through so that we can see them. So having presented this idea to the surgeons that, maybe we want to see these people in our pre-assessment clinic, and that the outcome may be that we'll be able to get medicine for the care of the older person specialist involved proactively post-operatively. That's been well received, and so maybe I'm being naive, but I think the tensions aren't yet really.
I think it helps as well if there's back and forth communication, so that you're not just doing your assessment and leaving it there. Like you're not just kind of step one is seeing one person. That there's back and forth, and if there is any tension, that it is worked through, or that where is someone coming from, and just to be able to work through it rather than kind of leave it and then, feel like you've done your bit. It's not like that. It's kind of a back and forth, and, you'll see patients at various points on their hospital journey or whatever, but just that you're able to have good lines of communication with whoever it is you're, working with and your colleagues.
I'm going to take a question or two just so we close out, perhaps from the audience, if we can. Mike, you're going to ask something.
We have a delightful comment from Michael Swart in Elder Statesman mode, which says, the future of POM in Ireland and Wales is in safe hands. You are more important for the patients than the older EBPOM speakers.
My closing experience is this, that Mike Swart, Monty, the team, Mike, and everybody around, I've been listening to them for the last decade or so, and we've been making small incremental steps towards this vision. But honestly, it's only really begun to get a foothold in the last 2 or 3 years. And I think that's because it's just beginning to be owned by a different generation. And I think Mike was alluding to that. I'm beginning to see people challenge the greybeards and beginning to just take it on and run with it. And I'm really pleased because I see things moving at a much faster pace now. I wish you all well in Ireland. I hope it all goes well in Ireland. We hope it continues to go well in the UK here and further afield internationally. I think perioperative medicine is in safe hands. It needs people like you. It needs people across the divides, the medical divides, to work closer together, I think. And I'm really thrilled to have been part of this session too. So I'd leave a final comment to anybody who wants to make it. Kim, you set up the meeting. Why didn't you close it out?
I'm actually delighted at this opportunity overall, because I do feel that there is, behind the scenes and people I've spoken to one-to-one, I do really feel that there is a push and a drive to promote perioperative medicine in Ireland. I understand it will take time, but I think we have enough interest that we can definitely make a change. There's a lot of us now. There's 5 of us here who've done Perioperative Medicine Fellowships who are coming home, and I think there's more to come. So I think in the next couple of years, we definitely will start to make an impact. And I do, I really truly believe that IPOMs will be the stepping stone to that change. I hope that in the future we'll all collaboratively work together towards that same goal.
Kim, thank you for that. That's super. Mike, unless there's anything further, I'm going to let these guys go away and change the world.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.